Welcome to the Season 3 premiere of the BRG Nurse Executive Podcast, where we will be discussing some updates on this podcast series, as well as our episode topic, which is Performance Improvement Solutions with Returns on Investment. Rejoining the podcast series for this episode is Bill Orrell, a registered nurse and managing director of BRG's Clinical Transformation Team. So let's get started.
Welcome to the BRG Nurse Executive Podcast. BRG is a global consulting firm that helps organizations in disputes and investigations, corporate finance, and performance improvement and advisory. BRG's healthcare performance improvement practice offers multidisciplinary services to healthcare organizations. We focus on implementation with innovative, independent, and data-driven solutions. In the BRG Nurse Executive Podcast, we discuss improving patient care by advancing nursing leadership. For more information about BRG, please visit thinkbrg.com. Now here's your host, Nick Chmielewski.
Bill, welcome back and Happy New Year.
Happy New Year to you too, Nick. Thanks for having me back.
What are your thoughts for BRG's clinical transformation service line as we enter into 2024?
I think it's going to be more of what we saw in 2023. I think there's still a focus on staffing shortages. I think some of it is getting better, but there's still a lot of pressure from agency staffing across the country. I think there's still going to be a focus on patient throughput from the front door in the ED through discharge from the inpatient setting. And so I think there's going to be a lot of activity in both the emergency departments and inpatient units. And I think there's a lot more focus now on surgical services. I think that the health systems realize that that's where most of the revenue is generated, and it's got to be as efficient as it possibly can. And we're seeing a lot of our clients with a renewed focus on making sure that surgical services are operating at the highest level of efficiency.
Great.
Well, Nick, what are your thoughts? We've ended the first 2 seasons of the podcast since we transformed it from a series of webinars to a podcast. This is the beginning of season 3. What are your thoughts about the first 2 seasons so far?
Yeah, this actually marks our 35th episode overall since our launch in August of 2022. We had those 9 episodes at the back part of 2022 and then 25 episodes last year in 2023, which was season 2. And we're going to continue with that target of about 24 to 25 episodes per year going forward and actually have our next few episodes already recorded. So I'm excited for their release and our listeners hearing them. Circling back to this being our 35th episode and our goal of 25 episodes this year, this means that this time next year, we should be celebrating the release of our 60th episode.
Wow, that's a lot of great work, Nick. You mentioned this is the beginning of season 3. I understand you're making some modifications in the coming year to the release schedule.
Yeah, so beginning in February, we're going to be shifting to a targeted release schedule of the first and third Tuesdays of the month.
And why did we make this change?
It's really about thinking about how our listeners tune in, many of which do so on their commute to or from work. We think that releasing it on a Tuesday rather than a numbered calendar day will avoid us trying to figure out what to do when we have a release that is scheduled to come up on a weekend or a holiday. And perhaps this approach may actually increase our listenership. It's also going to give us more flexibility to add additional episodes throughout the month if we want to. Whereas when we were doing the 15th or the 30th, it seemed kind of like, how do we fit the others in? Now, by just doing it on Tuesdays, we have other Tuesdays that are available if we want to throw in some breaking news episodes, so to speak.
That's great. I know you've already recorded some of the upcoming episodes. Can you give us a sneak peek of what we're going to hear over the next few months?
Sure, absolutely. Later this month, Ellie Kruk, who's the CNO from Northwestern Payless, she will be talking about making discharge lounges actually work. Dr. Jacob Miller from UC Health Air Care and Mobile Care in Cincinnati is going to talk about advanced EMS considerations for the nurse executive. Jim Ballinghoff from Penn Medicine, he's the chief nursing officer at Penn Presbyterian Medical Center, but also the CNE for the system. He's going to be joining us for 2 episodes. The first is going to be Advancing Nursing Practice with Technology. That's going to air in February. And then he'll be back for a second episode later in the year talking about healthy work environments. Dr. Patty Kuntz-Howard from the University of Kentucky is going to talk about key leadership challenges in addressing workplace violence. Later this year, we'll have Kristen Geisler from BRG's Clinical Economics and Quality team talk about healthcare quality essentials for the nurse executive. Andy Aguinobi, he's a physician. He was on a podcast last year. He's going to come back later this year and talk about his book, which is titled An Insider's Guide to Working with Healthcare Consultants. And then lastly, we will be continuing our series with Noreen Hudson regarding nurse executive fundamentals of the various departments that make up perioperative services. There's 2 episodes we will release on that later this year. One will be on the pre-anesthesia screening department, and the other will be on the preoperative unit.
That's a lot of good content already. Nick, we're always looking for industry-leading information or solutions to share on this channel. If a listener is interested in becoming a guest, what should they do?
Yeah, we welcome all nurse executives or nurse leaders to consider sharing their knowledge and expertise with their peers on this channel. And you can reach us at healthcare@thinkbrg.com. So if you are interested in coming and sharing your knowledge and expertise, maybe something informative that you've done, something industry leading, reach out to us by email and we can have that conversation about getting you on an episode.
Great.
So, Bill, I'd like to circle back for a moment and talk more about the great work that BRG is doing with our healthcare systems across the country. Last year, we chatted with Peter Chadwick, and he discussed the significant financial constraints of 2023. What are the greatest problems our clients are asking us to partner with them on right now in 2024 as this year kicks off, both in clinical delivery, but also in other aspects of performance improvement?
I think the focus will still be the same as in 2023, Nick. I think most health systems are facing many financial challenges this coming year in 2024. There's increased pressure on margins for health systems across the country. I think the lenders are starting to put pressure on health systems that they need to make changes to operations to change that outlook. And I think we've seen some estimates that a third of all health systems are in some sort of financial distress going into this year. And so focus on margin improvement activities needs to be front and center of the leadership teams and the frontline leaders of all health systems across the country. I think we talk a lot about clinical performance improvement, and we talk about the emergency department and the need to get patients in and get them out or admitted into the right level of care. We've talked about a lot about improving patient throughput. We've talked a lot about optimizing surgical services in the clinical realm, but there's also a need to really focus on the revenue cycle and making sure that health systems are collecting every dollar that they can, that they have appropriate relationships with their payers, that they're getting paid for the services they're providing. There's a renewed focus on making sure that their supply chain and materials management operations are as efficient as possible, that they're paying the right prices for all the what we call non-labor expenses that they can, that they're utilizing the right supplies and implants and physician preference items. I mean, that their relationships with their suppliers and their GPOs are appropriate and efficient. I think there's all across the board there's a need to look at every facet of operations across health systems, across their ambulatory network, to make sure that they're really focused on margin improvement in 2024. And at the same time, making sure that the goal of margin improvement activities is to make sure that the health systems are solvent and their doors are open for serving their communities. And at the end of the day, it's all about improving patient care for the communities that they serve.
How do we within BRG's healthcare performance improvement practice know that we are making a difference? I know that we are, but how do we know that we're making a difference, particularly as it comes to revenue or cost reduction for the clients that we serve?
It's an ongoing measurement, right? We can see it in their financials. We can see it when their bottom line improves through a series of performance improvement activities over a 8, 10, 12-month change management process. We can see it in the way that their lenders and the bondholders look at them and rate them once they go through a performance improvement engagement, if you will. But then you also see it takes longer, but eventually, particularly when we do some of these clinical performance improvement initiatives, you see it in their quality ratings, and that's why I'm interested to hear the conversation you're going to have with Kristen. Is you start to see their quality metrics improve over the course of. There's a long tail on those, so sometimes it takes 3 years before you see it, but it does happen if you really focus on improving patient care. Your quality metrics and your publicly reported metrics improve.
And from an ROI perspective, you mentioned earlier about periop. What's some of the type of the work that the perioperative services team does to help improve those bottom lines?
So the real improvement is you're getting more surgical cases through in their existing chassis. It's whether it's running fewer rooms more efficiently or it's bringing more volume into their existing chassis. The outcome is that they're improving the overall financials of the health system by bringing more surgical cases through in a more efficient manner, or it's reducing the expense of running fewer rooms with fewer staff more efficiently and using the right instruments and implants at the right time. But the main thing is really improving the perception of all of the stakeholders that are interacting with surgical services, and it is primarily the patient, but it's also surgeons and anesthesia and nursing. It's improving their experience on a daily basis.
What I hear you saying is that our perioperative surgical services team works to really create a better, healthy working life environment. And while that may sound like that's something that's soft, that we have real dollars that are attributed to the enhancement in operational efficiencies that come from stakeholder buy-in and enhancing the work-life effectiveness of all of those that are in that division. Is that an accurate statement?
As usual, you said it much better than I did. That's exactly right. It's really you want the surgeons to bring more cases there, and they're only going to do that if you make it easy for them to do that. You have to make it easy for them to schedule their cases. You have to make it easy for them to get the pre-admission or pre-anesthesia screenings done. You really want things lined up for them to just walk in the door and do their cases in their block time and then get out. That's what they want. And then they want to know on the back end that their patients are being taken care of in the most efficient and effective manner. And it's the similar expectations for anesthesia and for nursing staff. And so it's really just making sure that everything within surgical services is running as efficiently as possible and improving really the perception of all of those stakeholders at the end of the day.
So let me ask the same question then, really, for case management and care transitions and inpatient length of stay. Where's the value? Where's the return on investment coming from in performance improvement where organizations really have the opportunity to improve their bottom line?
This one is actually more obvious for most health systems than even the surgical services one. It's really everywhere we go across the country, there are patients boarding in the ED. You know this better than anyone.
Yeah.
And so at the end of the day, you're improving the throughput on the inpatient side. You're improving the utilization of those inpatient beds that are just a scarce resource and getting those patients out of the ED into an inpatient bed, which when you're providing inpatient care, the ED is not where you want your patients to be or to be stuck. And the ED nurses don't do inpatient care. They do emergency care. They do trauma. They do short interval care of patients. And so getting them into an inpatient bed is where you want them. And so the short sell on the throughput side is making sure we're using those inpatient beds as efficiently as possible. We're reducing the inpatient length of stay. We're reducing what we call excess patient days and getting those boarding patients out of the ED, hopefully in large numbers.
Yeah. What are some of the strategies that our team looks to employ for that?
It's really multi levers that we have to pull. So we start with some of what we call foundational steps, and it's really making sure that we're adequately staffed and trained and have clear roles and responsibilities for case management and social work and the UN nurses, that we have a physician advisor that can support that group, that they're, have scripted conversations every day on every patient on the inpatient setting, that everyone is clear from the bedside nurses to the hospitalists and other physicians to, physical therapy on what the estimated day of discharge is. And then how do we progress together to make sure that the patient is getting out by that estimated day of discharge or even sooner if we can. And it's just making sure that we're communicating all across the care team on what the expectations are for this patient's progression of care. And then we really start to pull some levers in how do we actually assign beds? How do we cohort like patients together so that the care teams can stay on the inpatient units and care for that patient population and spend less time bouncing between units across the non-value added time, bouncing between units and caring for their patients. That actually does add a lot of value and decrease length of stay, is just making sure that we're cohorting like patients together and cohorting the hospitalist teams and the physicians with their patient populations like nursing has always done it. So that's a big thing. And then just making sure that we're communicating from the front end to the back end what the expectations are for that patient's length of stay. Going into 2024, throughput in the ED, as well as staffing, is going to be a focus across the country. So I'd love to hear from you what you're thinking about going into 2024 from an ED perspective and what health systems really should be thinking about as they look to improve operations in the ED.
Yeah, so that you mentioned boarding before, and clearly I think that's what every ED across the country right now is screaming about is our boarding is way up and it's really impacting our ability to operate. And so while you certainly can do standalone work in the emergency department to improve performance improvement, the best way is to leverage enterprise-wide solution looking at throughput improvement. So part of it is inpatient length of stay reduction. Part of it is opening up the beds on the inpatient side. And with that, in collaboration with that, looking at how do we improve the admission process from the ED to the inpatient side?
Mhm.
What does that look like? How do we streamline the bed approval, denial, escalation process so that when nursing has a question about this patient being appropriate for a unit, you can get that situation resolved relatively quickly and you don't have nursing banging their head up against a wall in the ED for 4 or 5 hours trying to get this patient to their final level of destination. And so that's the collaborative components. But then, specific in the ED, you can make a difference just by looking at within the four walls of the ED. Left without being seen is something that the ED owns. Despite how bad your boarding is, you can find a way to get a provider, a qualified medical provider, in front of that patient. And there is real money associated with that in nearly every state across the country. The one exception being, of course, Maryland, because they don't really operate on a true fee for service model. And so when you have a high left without being seen, that is money walking out your door. And fixing that problem and getting those patients seen not only is the right thing to do for patient quality, patient outcomes, and patient experience, but it really does impact your bottom line as well.
I want to press on that a little bit because we're fortunate to work with a lot of different sized health systems across the country, from academic medical centers to small and medium sized community hospitals. And when we talk to leaders at these health systems, they seem to narrowly focus on those patients that are boarding in the ED, the ones that they can't get upstairs, the ones that are taking up valuable real estate in the ED. But they often sometimes forget about that other 70% of their patient population that are being treated and released. And you talked a little bit about left without being seen and the work you can do about a provider and triage. What are some other things that health systems should be thinking about in dealing with those lower acuity patients, or maybe just the patients that maybe not lower acuity, maybe that kind of ESI level 3 that are going to be treated and released? What should they be thinking about to impact their throughput from the front door of the ED through discharge back home?
There's a variety of models of care that are out there, and there is no one right solution that every ED should be employing across the country.
Mhm.
You really have to look at what is the size of my ED? What is the size of my volume? How much space do I have? What's the architectural footprint of my space look like? What's my admission rate? And what's the type of patients that are coming in? And then, based off of all of those parameters, then evaluating those care models and figuring out, okay, given this scenario, what is the best care model that I can employ in my organization, knowing these constraints to provide care for all patients, not just the sickest patient, not just the patient that's going to get admitted, but also the patient that comes in that is truly low acuity. Maybe they just have an upper respiratory infection and frankly could have been better served in an urgent care, but they end up in your ED. Or that ESI level 3 patient that needs to be in the ED but can wait. And because they're stable in many EDs, they actually have the longest length to stay because they need a complex workup and they take the longest time to be seen. And a belly pain is a good example of those patients that just they wait for such a long period of time. Do we use a vertical care model that includes ESI level 3s? Do we put in place a fast track that excludes ESI 3s? Do we have a dedicated fast track that is staffed by an APP? Or do we group all of these patients together and have them seen by all providers? Do we go with geography-based staffing on the provider side, or do we have it next team up where team one takes patient A, team two takes patient B, and they keep alternating back and forth? There's no right solution for all of those. And I can give you studies on all the cases of why one worked in one particular organization, but another did not in a different one. It's really about finding what is that right solution for that individual client. And so that's where we can be helpful. I've been in over 70 EDs in 18 different states, and the rest of our team on the ED side also has a lot of great experience in different states and different size EDs. And it's about applying that solution that's going to work with that client that also is unique to their culture that they can own. Beyond left without being seen, though, the other components are, where are there labor opportunities in the ED to improve things? Do you have your staffing aligned with your patient demand on both census and then also on arrival pattern? And on the provider side, I would also question, what does the utilization look like? Is there wide variability in lab utilization and in imaging utilization from one provider to the other? What are your turnaround times on those issues? And are there opportunities also comparatively based on like organizations? Is your utilization really low? Or is it incredibly high? And if it's incredibly high, does it need to be that high? Because doing an MRI takes time, doing a CAT scan takes time. And if it's not a necessary test, I would question, is that appropriate? Can we get a referral on an outpatient basis and get something like done, particularly for MRIs? So those are some of the things that we focus on, and particularly around left without being seen. A lot of those projects for us yield millions of dollars of revenue, increased revenue for the clients that we work with on an annualized basis.
Well, Nick, let me throw you a softball here. So, what are you seeing EDs and health systems around the country doing for those patients that are essentially seeking primary care services in the emergency department when they whether they may be just what we used to call frequent flyers to the ED, or maybe just patients that don't have a primary care provider, and so their only option because of real or artificial barriers to care is to come to the ED for routine care. What are you seeing health systems do to deal with or address that in their communities?
Four things. Let's start with the easiest. The easiest is just education across the board. So there are some markets in the country right now where you see billboards that do education that says something along the lines of, did you get stung by a bee? Go to an urgent care. Did you get stung by a beehive? Go to the emergency department. And I'm oversimplifying it, but something that simple from a patient education perspective on billboards with names of your institution and whatnot can really start to drive people to the right location before they even end up at your emergency department. And then once patients come to the emergency department, in some pockets across the country, there are places where they will have a screening done by a qualified medical provider. It's determined that they do not have an emergency medical condition, and then a referral from that initial screening that is EMTALA compliant to another definitive care location, whether it be an urgent care or for a follow-up visit or things of that nature, and really stop the ED visit, if you will, because we've determined that emergency medical condition does not exist. So that's the second component that can be done and done quite well if it's the right fit for the culture and the nature of that organization. The third thing that you can do, and this requires a lot more work beyond the ED though, is looking at referral management centers. All right, we've got a large multi-system health system, and we've got patients that are coming in and they're being seen, and we need to refer them for ortho on an outpatient basis. But yet these patients are bouncing back into the emergency department because they have fractures or sprains and they've run out of their pain medicine, and they can't get into ortho. Finding out ways to, do we have enough specialists in the community, determining that. If not, we need to recruit and get more specialists. And then beyond that, having the right scheduling mix on an outpatient basis so that when an emergency department patient is discharged and they need a specialist follow-up, they can get in whatever time frame is appropriate based upon their condition, whether that be 2 days, 2 weeks, or 2 months. So that's the third thing, is appropriate outpatient referral centers. Our strategy and ambulatory services team does great work around that. And then the last thing, which is back in the ED, is having complex care plans for high utilizers of emergency departments. And that would be specific to John Doe that comes in. Everyone knows them in the ED. You're known well by name. In some cases, they're visiting the ED more than the staff that's working there, and understanding that this is our care plan for this particular patient, which we are going to follow every single time unless it's determined that they have another sort of emergency medical condition. So really a four-pronged approach.
It's great. That's great, Nick. I think we're going to be seeing more of that in the new year.
Yeah, there's a lot of talk right now also about virtual nursing. I wanted to talk on that real quickly. What kind of work or solutions are you seeing some of our clients use as it relates to virtual nursing as both a labor solution and also an efficiency perspective?
I think the perspective on that has changed over the last year. There are some vendors out there with some really good technology helping to facilitate those programs. What I think health systems expected going into, the dawn of virtual nursing a couple of years ago was that there would be some FTE savings or FTE efficiency from having these programs, and that's not what they're seeing. I think what our clients that are using that technology, the benefit they're getting from it is lower turnover in their new grad nurses. Those nurses that are within year 1 to 3 or 4 or 5 of their career, because the virtual nursing technology allows them to have a more experienced RN looking over their shoulder, serving as a resource. It really is a benefit for those new grad nurses working night shift, often with limited supervision in some of these health systems, to have someone, a more experienced virtual nurse, as that resource to call on when they have questions just about basic nursing practice. I think that's the benefit they're seeing is impacting that turnover that for the past almost a decade we're seeing in the new grad early career nurses, that they come in and are just not prepared to work at the bedside, but having this virtual nursing concept implemented has really started to make a dent in that turnover. That's the benefit the health systems are seeing. It's not an FTE savings.
Interesting. Well, hey, it's been great catching up with you. Happy New Year. And any closing thoughts as we wrap up this episode?
I'm really proud of this podcast, the wide variety of guests we've had over the last year and in this upcoming year. It's just amazing. Nurses, nurse executives, physicians, professional organizations. We're really touching all aspects of healthcare with this podcast. And it's grown more than to just nurse executives, but providing a lot of good content. And I'm excited to see where it goes. And we're out and about around the country. And if there are other nursing leaders or professional organizations that would have interest in serving as a guest on the podcast, please reach out, as Nick mentioned earlier, at healthcare@thinkbrg.com. Nick, thank you again for everything you're doing for the podcast, and Happy New Year.
Thank you.
You've been listening to the BRG Nurse Executive Podcast, which focuses on improving patient care by advancing nursing leadership. The views and opinions expressed in this podcast are those of the host and podcast guest and do not necessarily reflect the opinions, position, or policy of the guest employer, Berkeley Research Group, or their other respective employees and affiliates.